Hello, everybody. My name is Dr. Emery Pitcel. I am the owner and chiropractor at Rothrock Chiropractic in Rehabilitation. We are located here in State College, Pennsylvania. We are so glad that you could join us here in March of 2025. We are continuing our podcast series on Condition of the Month, COTM. And this month, we are diving into knee osteoarthritis or osteoarthritis of the knee. Now, osteoarthritis is frequently called by a lot of practitioners OA, right? Osteoarthritis. Generally, if somebody's saying that they have arthritis of the knee, they are saying that they really mean they have the osteoarthritis version. Incredibly common, especially in the elderly. Let's start to kind of walk through and give you, starting with a brief anatomical lesson on what is osteoarthritis of the knee. Of course, the knee is that hinge joint that is located between the femur and the tibia and the fibula, so thigh and the lower leg. And it's a hinge joint. It really just bends and it opens up. It's those two main movements. Now, in the joint itself, if we are citing here from our Netter's atlas here, in the knee joint itself, we are going to have at the end of the bony articulations, you're going to have a lot of cartilage. Now, in this depiction here, this is like a younger, healthier type of knee. So we have a lot of productive cartilage in here. This is the front of the knee. That's what kind of the condyle looks like. Lateral here on the side of the fibula, medial here on the side of the tibia. And this is the back view of the knee if we're going deep and everything. Again, the lateral condyles here, side of the fibula, the medial condyle here on the side of the tibia. And what happens with osteoarthritis is if this cartilage, when this cartilage completely degenerates or goes away or disappears and it fails to regenerate, it fails to heal itself back up, then we get to a point where that cartilage isn't in that joint line anymore, kind of like that squishy, gooey shock absorber. So instead, what ends up happening is we get to a point of bone on bone, right, where we're getting a lot more of this friction rub. And as that bone on bone happens, the changes that we could see, three big changes that are often seen on x-ray, is that that bony joint line will get a lot more white, which is known as becoming sclerotic. If there's enough of that bone on bone, then you'll actually get some bony overgrowth on the edges, which are called like bone spurs or osteophytes. And then the last is you'll see that instead of being this nice, healthy, uniform joint line, there is narrowing and sometimes ununiform narrowing. So those are kind of the three big signs that would then tip off a physician to look at an x-ray and say, hey, you have osteoarthritis. Now, most times when we look at those x-ray changes, that's not immediately a guarantee that you have osteoarthritis and that you're in pain. That's why this second part of the podcast is very, very valuable. You kind of have to combine the fact that you have the x-ray findings and tailor that with the symptoms. And here are going to be some of the classic symptoms that we would see. That pain that increases gradually over time. Most times osteoarthritis isn't going to go from 0 to 60. It's going to be over months or over years that pain gradually increases and worsens and worsens. And then when you do kind of get into more of the peak of your episodes, patients are going to feel a lot of stiffness in the knees, especially in the morning, where it's going to take 30, 60 plus minutes to loosen up the knees and finally get them going. On the stairs, typically patients and clients are going to have a tougher time going down the stairs than up the stairs, but both directions are still going to be fairly challenging. The longer that somebody walks on an osteoarthritic knee, typically that means that the pain is going to get worse over that time. And standing in one spot for very long times, and quite honestly, sitting in one spot without really moving that knee around either is also going to create problems. And then when things get really bad enough, it's not uncommon to see instability existing across that knee, and especially some weakness with some squatting in the fear that that knee is actually going to kind of weaken and give out and buckle on a patient. So that's a pretty comprehensive list of the symptoms there. What are kind of the mechanisms of injuries? What sort of things do we need to be looking for? Well, the number one cardinal and obvious is age. We're talking about somebody that is a geriatric person who's had 60, 70, 80 years of loading that knees, having that cartilage kind of wear down and break. We like using the phrase in our office of wear and lack of repair more than wear and tear, because there always is wear and tear, but at a certain point, whether due to an injury, poor diet, or just getting older, that repair phase after the wear is not going to keep up, and that injury is going to add up over time and create pain. A previous trauma is going to be another thing that causes a huge episode of wear on the cartilage. So think of somebody who's had a really bad sports injury, like a blown out, terrible triad, ACL, MCL, and medial meniscus blowing out. Um, or someone that was in a really bad car accident and slammed the knee into the dashboard really hard and created a lot of trauma right there. Somebody that missed the curbside, stepped off and really buckled out that knee and created a lot of knee damage. The list goes on, but the idea is some sort of trauma. Trauma is generally going to accelerate osteoarthritis. Somebody who's overweight, once again, a lot more wear and compression on the knee. And it's also more than just the wear and compression that lives on the knee as well too. It's also the fact that when you're overweight, that changes fatty as a hormonal profile, and that's going to keep people in a bit more of an inflammatory phase and prevent that lack of repair from happening at the knee. And then also job and sport related. We find that people that frequently work in construction type industries are going to have a lot of squatting and bending and loading of their knees. In sports, typically the athlete I like to pick on the most is the catcher in baseball that sits in this prolonged squat. But either way, there's a lot of sports running with this repetitive pounding. Um, could have those that are football players that have had, like we said, a bit of a long career with a lot of hitting the gym and a lot of load on those knees over time. So those are kind of ways that the osteoarthritis is going to either sort of reasonably set in or potentially set in a little earlier. So that's kind of the issue. Brief anatomical lesson, walked through the symptoms that we see, walked through kind of the mechanisms of injuries as well too. So now we get into this side of the board. This is solutions based. So what can we do at Rothrock Chiropractic and Rehabilitation to improve these knees? Now, obviously, if they degenerate enough and they get to a point of being problematic enough, then we're not going to worry about what we could do in here. That's time to talk to an orthopedic specialist and see if it's time for a knee replacement. But assuming we're not at the point of needing a knee replacement, we're always going to start with a rehab first approach at our office, and we're going to start with a McKenzie assessment and protocol. Now, with the McKenzie method, what we are going to try to establish is if that osteoarthritic knee has a directional preference. So what way does it need to be worked into to overwhelmingly improve pain and function and muscle tension? A lot of times with a knee that's osteoarthritic, it's going to be repetitive flexion. So that's taking that knee and repetitively bending it and working it in that direction. Send that patient home working with it 4 to 6 times a day, more if needed, really working that repetitive knee bend, that knee flexion. Once pain and function kind of improves over time, then we love to give patients more strengthening exercises, have them really focused on getting the VMO, getting that hamstring tension under control, really kind of working on some balance and stability with some like one-legged circles or balance pad or star pattern challenges to really kind of strengthen things, not just across the knee, but the ankle and the hip generally have to get strong and stable to support that knee underneath. So that is kind of the active side of things of what the patient is going to do at home. When patients come into office, we love being able to tackle things that patients can't accomplish for themselves at home. So they could do a lot of these exercises at home and we walk them through the plan and the procedures and the know-how. But then we also really like to do muscle therapy in office. That's our second tenet. So really kind of doing some pin stretch. If we figure out that flexion is that directional preference, it's really nice to work through repetitive bending and repetitive flexing while digging into the joint line and releasing a lot of the hamstring calf tightness and getting a good reset on like the distal quads. Also trigger point release just in general with that knee in place, kind of just again, really getting deeper into those tissues, get that neurological reset and blood flow to them to calm things down. And last being chiropractors, of course, we love our chiropractic manipulation therapy. What I'll generally do is if it's an osteoarthritic knee, I'm generally not going to thrust on that. I find that a good heavy mobilization into repetitive knee flexion is really effective, and especially kind of putting a little bit of a block on the back of that knee really opens up that knee and those osteoarthritic um, components at that knee and really heals things along pretty nicely. It's also rather nice, even if the functionality only improves at the knee by 5-10% by doing some stabilization and some work at the lumbar spine and at the pelvis. I think it's always just a good idea to work upstream from that and make sure that everything at the pelvis, neurologically, nerve space wise, is as open as it possibly can be. And that, like, the pelvis is kind of like as positioned as correctly as it can be. So that way we can be confident that the knee isn't at all paying for the compensation load of something being off at the lumbar and the pelvis. So that's a pretty good walkthrough. We hope here, rehab first, lots of muscle therapy, and of course at the very end, getting after the chiropractic adjustment and using those three prongs to help heal, rehab, and manage knee osteoarthritis. Well, we want to thank you all if you made it to the end of this video here. Thank you so much for walking through. We hope that this was very insightful, very helpful. If you found it to be, share this video with somebody who you know can benefit from hearing it. Hit a like, a comment, and subscribe to our channel to get more content exactly like this. But in the meantime, from Rothrock Chiropractic and Rehabilitation, I'm Dr. Emery Pitcel. Thank you for joining us for Condition of the Month here in March of 2025. And everybody have a great month of March. Spring is on its way. Everything's looking up. Be happy here in central Pennsylvania. And thank you for watching. Take care until next time, everybody.